minutes expanded in proactive attitudes save hours of reactive attitude postoperatively. So the patient should have realistic expectations. We know that contrast sensitivity will be reduced by 5 to 10% for far vision. And as Dr. Khader Afraj, you need to pick and choose which is the best or the most practical premium IOL for your patient. So choose the IOL that best suits your patient. You should understand the types of refractive IOLs. There are refractive and refractive premium IOLs, and they are based on different designs. As you can see in this diagram here, it's made of two components: a monofocal optic in the center, and back surface of these trifocal lenses is a refractive element, and they have different spacing and different heights. This is called kinoframe. Some of them have equal heights. The height actually splits the light energy, whereas the spacing gives you different power. So the larger the space, you have more intermediate vision. The further the height, having different heights splits the energy of the light at different levels or at different zones of the premium IOL. You have to also understand the type of material that best suits your patient. For example, a posterior capsule opacification is more common with a hydrophilic lens. So if you're planning to perform a DESIC for this patient in the future, it might be more wise to use a hydrophobic lens. Also, hydrophobic are better used for younger patients because there's lesser risk of posterior capsule opacification. You have to identify the intermediate working distance for your patient. The American Occupational Safety and Health Organization has shown that patients with 2 meters or more of height have an intermediate vision of 80 centimeters, whereas your average patient has an intermediate vision of 60 centimeters. But as a rule of thumb, usually the intermediate vision lies at the patient's arm length. So try to choose the trifocal lens that can best address the patient's intermediate vision. Myopes seeking these types of refractive procedures are usually more spoiled. They're used to working at a very close working distance. So they should understand that their working distance, their intermediate working distance will be shifted slightly more away from them post-operatively. Patients should have realistic expectations. So reaching a J1 or J1 plus is usually an unrealistic expectation. This is usually only accomplished physiologically in the young patients, less than 40 years of age. Mention cataract halos and glare will be reduced greatly, but not disappear. Most patients who have cataracts usually have halos and glares, so this will continue postoperatively, but it will be slightly reduced. There is no trifocal IOL without a dysphotopsia, and that does not exist. So usually it's not usually disabling, and usually months later after the procedure, something happens called neuroadaptation. The patient no longer becomes bothered by these dysphotopsic symptoms. Also take into consideration that there are trifocal lenses that are pupil dependent and that there are others that are pupil independent, as Dr. Khader Afraj mentioned in his talk. So you need to understand which type of lens you should choose. Most of our patients in Saudi Arabia are usually night dwellers. So night driving is an issue here. So you should keep in mind that when the pupil is dilated, light is refracted more towards the periphery for better far vision, and light is diffracted at the periphery more in the center, at the periphery more than the center. So in this area here, the patient sees far when his pupil is dilated at night. When the patient starts reading, the synkinetic reflex kicks in and the pupil constricts, and at the center here, the light is equally distributed for far and near. Centration is very important and imperative for these lenses. A slight decentration can give you very miserable and horrible results. A slight tilt can also give you very poor results. It's because of the design of the lens. And this was published by Paulo Vinciguerra, and he measured the effect of tilt and decentration by his OPD scan and tracy wavefront system. Recentration, he has shown in his study that recentering these IOLs can improve vision. He also advised that haptics, if you're using this type of design, should be kept at 6 and 12 o'clock so that the lens can be slightly decentered nasally. And talking about centration, we have something called the pupil center, as you can see here in the diagram, and we have the visual axis. The best centration for these lenses, whether it's an aspheric, a toric, or a trifocal diffractive, is between these 2 points, between the Purkinje one and the center of the pupil. Otherwise, you can have exaggerated halos and glare. This is called angle kappa. So if you perform a corneal topography and the patient does have a significant angle kappa, these patients should not be implanted with these types of IOLs. Also, it was shown that patients who had prior cataracts and they were implanted with trifocal lenses had a better or more satisfaction than patients who are actually 20/20 with glasses or with contact lenses, because of the issue of glare and halos. So it's best to use corneal topographies than depend on the automated autorefractometers, because you get here more points, and also because of the angle kappa issue. Always exclude patients with higher order abrasions, because they're going to be severely dissatisfied because of the exaggerated halos and glare post-operatively. Also, it's important to eliminate any astigmatism. Any astigmatism more than 0.5 diopters is considered significant. So, in conclusion, remember the 9 rules or advices. Patient counseling. Patients should have realistic expectations. Address the problem of reduction of contrast sensitivity. Mention that there are going to be halos and glare, and these halos and glare will reduce because of the neuroadaptation. Patients should have realistic expectations. Yes, he will be able to read the small prints in a newspaper, but not the very fine prints seen in medication pamphlets. Use corneal topographies to exclude patients with high order abrasions. Use corneal topographies to exclude patients with angle kappa, and always center the lens between the Purkinje one and the center of the pupil. Remember Vinciguerra's advice to put the haptics at 6 and 12 o'clock, and choose the best IOL that best suits your patient and his intermediate vision. Always eliminate any astigmatism, because that can mess up your final result. And thank you for your attention.